It's wonderful to come to this lovely venue and this wonderfully organized conference. I'll be speaking on antiviral drug resistance in HCV. They are progressively improving treatment options in treatment of HCV, and the DAs have changed all the paradigms and the responses rates are beautiful. But still, drug resistance and treatment failure remains an issue in some of the patients. This will be the framework of the talk, the life cycle, the currently available drugs, some concepts on HCV resistance. How do these HCV polymorphisms affect the DAA regimen? Should we perform pre-treatment HCV resistance testing in all patients? How do we overcome the resistance, and what should be the strategies of treatment of DAA experienced patients? So let's go to the first of these. This is the HCV life cycle. We have receptor binding, endocytosis, uncoating of RNA, this translation, this RNA replication, virion assembly, and release of virus. The NS5B RNA-dependent RNA polymerase acts on replication of HCV RNA. The NS3-4A protease is responsible for escape from the innate immune response. Then the NS5A replication complex and assembly. This acts on replication complex and assembly. Now, these are the targets for treatment of HCV. And we see that the previrs act on the protease, the asvirs act on the NS5A inhibitors, the buvirs are the NS5B inhibitors. And the currently available drugs, as we know, out of these 4 regimens which have been recommended, the first 2 which are in the red box, which is soft Dacla and soft Velpa, is available as a pangenotypic combinations in India. And among the genotypic specific combinations, only ledespivir based regimen is available in India. So the red regimen, which are here, soft Velpa and soft Dacla, which is pangenotypic, are available in India, while ledipasvir as the genotypic specific combination is available for Geno 1. Let's look at this ASL. This slide summarizes the AASLD recommendations for treatment of HCV, and I'm only going to focus on Geno 3. If you look at Geno 3, the recommendations are that what is down below here. Geno 3 with compensated cirrhosis should undergo resistance testing, and if patients have NS5A RAS for Y93H for velpatasvir, we add Reba or treat with a combination therapy of soft velpatasvir and voxilaprevir. Similarly, the genotype, the resistance testing is recommended for the combination in Geno 1, which is for elbasvir and grazoprevir for Geno 1. But we don't have the recommended regimens available. So what should be the treatment options for India? So in India, we have velpatasvir, which is across all genotypes, along with decladespivir as an option, and ledipasvir as the option for Geno 1. In patients who have combination therapy, since we don't have voxilaprevir, extending duration of therapy or addition of ribavirin are the treatment options. Let's look at some of the basic concepts of HCV drug resistance. There are various genotypes, and some newer genotypes like genotype in Indian patients going to Canada have been also reported, but dominantly we have Geno 3 in India. The genetic diversity of HCV is the basis of emergence of drug resistance. HCV is a RNA virus. It replicates very rapidly and produces almost 10 to the power 10 to 10 to the power 12 virions every day. And this production of new virus is dependent on the RNA polymerase that has a low error repair capacity. So constantly new and novel variants are being produced. Most of them either do not survive or are eliminated by the host response. But some of these do survive, and that is what leads to decreased susceptibility to the drugs used to treat the virus. So the consequence of this genetic diversity and new novel variants is that, one, the immune vaccines do not act, and second is the antiviral resistance happens, leading to treatment failure. A word on polymorphisms. There is a reference nucleotide and therefore a amino acid sequence which is defined for each genotype. We hear the word Y93H. So what is Y93H? So the NS5 and Y93H refers to the amino acid at position 93. The Y at the initially is the reference amino acid in that position. Y stands for tyrosine. And H is histidine, which it has come to replace. The RAS is associated, or which is resistant associated substitutions are associated with decreased susceptibility of the virus to the DA. The NS5A inhibitors resistant viruses are the most significant, have implications of therapy, and they can persist for years. Those for NS3/4A inhibitors are less fit and they tend to go away with time from the peripheral blood. And we rarely have RAS for NS5B. But just the presence of these resistance associated substitutions doesn't mean that we cannot use the virus. We cannot use the drug. We use combination drugs, and this combination of drugs is what increases the barrier to resistance. So we can have baseline polymorphisms or polymorphisms which appear after the introduction of drugs. In either case, combination of drugs remains the answer. So therapeutic failure happens from three basic things. You can have host issues where you have, for example, advanced fibrosis and cirrhosis. The type of virus, Geno 1A and Geno 3, are worse. Whether the regimen was well adhered to, whether there was ribavirin added, what was the duration of the treatment, all these have implications on treatment failure. Also, one must remember that it could be a co-infection or a reinfection or genotypic errors. So what are the impact of these HCV polymorphisms on the efficacy of the DAA regimen? All antivirals are not equal. This sort of slide, you see the green dots are good and the red dots are the least favorable. So if you look at the resistance profiles, the first generation protease inhibitors had bad resistance profiles, while the nuclease polymerase inhibitors have the best resistance profile. And the yellow dots, which is the protease inhibitors of the second generation or the NS5A inhibitors, have average resistance profiles. These are some of the common mutations, and the color coding is what defines the level of resistance. We look at velpatasvir on the left hand column, and you look at this is genotype 3, and you look at Y93H. If you find this is more than 100, so it's if Y93H is present, they're likely to have significant resistance, and that is why the AASLD guidelines recommend for testing of Y93H in patients who are going to be treated with velpatasvir in genotype 3. So what is the impact of these polymorphisms on therapy? The clinical impact of HCV polymorphisms is affected by many other things, as I mentioned. Whether the patient has cirrhosis, what is the regimen used, and how long it has been used. We can continue to use DA by adding other drugs, increasing the duration of therapy, or addition of ribavirin. This was data on velpatasvir and sofosbuvir in Geno 3 infected patients with compensated cirrhosis. These pink boxes are Y93H, and the gray is overall. The green is no resistance associated substitutions, and this brown color is any NS5A RAS. If you see that those who had Y93H have very poor response to velpatasvir and SOF in Geno 3 with compensated cirrhosis. So should we treat, we have a lot of Geno 3, so should we go ahead and test for all these pre-treatment resistance in all these patients? Well, there's an issue. Resistant testing is not easily available. It's the cost is an issue. And even for labs where it is available, you look at the cost which is there in one of our premier labs, the costing is almost 72,000, which is as much if not more than the cost of therapy which is being given to these patients. It complicates the simplified treatment algorithm. There is already an excellent response of more than 95% in patients who have pangenotypic, who are being given pangenotypic DAAs. This resistance can be overcome with drug combinations. The other problem is, even if you do test and you find that there is resistance, regimen containing WOX are not being marketed in India. So if we are going to look for RAS, where should we consider RAS? First is, if you're going to consider giving Elbasvir and Grazopavir, which is not being available in India, and we are not really going to look at it. This is for Geno 1A. SOF and Ledipasvir, NS5A RAS for Geno 1A treatment experienced patients. And this is what really affects us, is we have, if you're going to use either Velpatasvir or Dacla, and we have Geno 3 induced cirrhosis or treatment experience, this is the only condition. If you want to test, this is the place to condition. And your options would be to add ribavirin or use a WOX containing regimen. So how do we overcome this resistance? We look at, characterize the patients where we worry. We look at patients who have cirrhosis or previous treatment failures. You consider extending the duration of therapy or addition of ribavirin or adding other drugs. What happens when we add ribavirin? The same data which I showed you, when ribavirin was added, if you look at this pink one, this is Y93H, where the response rate was only 57%. When we add ribavirin, the response rate goes up to 89%. So addition of ribavirin is an important factor in managing such patients with cirrhosis. So what should be the treatment strategies for DA experienced patients? There is this, if you have WOX available, there was this data which showed that there's no impact of RAS substitutions on efficacy of treatment with SOF, Velpatasvir and WOX for 12 weeks. And not only is the efficacy very good, there is no new drug resistance which develops when you, even if this treatment fails. So in the previous treatment failures, I will stick to Geno 3. You consider SOF, Velpatasvir and Voxiprevir in patients with compensated cirrhosis. While it's not being marketed in India, this drug combination are available on compassionate use program. And there is some data which is available from India. First is this, you can reuse the first line treatment options by increasing duration of therapy or by these new drugs. And there is a small data on 15 patients which was given in India, which has come from Dr. Dhiman's group. To conclude, ladies and gentlemen, drug resistance of DA is of clinical significance in a few patients with HCV. Resistance testing is not usually done in clinical practice, and treatment options should include ribavirin addition, extension of therapy, or get the compassionate use Voxiprevir in India. Thank you.